And get started this meeting. We're going to pick up where we left off. I think we had a good discussion about this definition, but we haven't come to a conclusion, so I am going to make the recommendation that we put it on hold, return it to the subcommittee, and then revisit that at the next meeting after we've had the benefit of legal and OAL to weigh in on it. The items A through Z, however, refer to, the shelter setting traditionally. So I think we might be benefited by going through those, getting everybody's input, and seeing if we can put that situation to bed. Dick?
Okay, yeah, we'll go as far as time permits, and then we got other agenda items that you want to get to. So I think we'll just start with A, and I want to get Alan's input and the audience and the board or the committee.
I'm sorry to interrupt, just so everybody watching knows, we're on CCR 2030.6. Okay. Still minimum standards, animal shelter medicine, and fixed facility.
Okay, item A.
Who can argue against that?
Good. B.
Great.
C. D.
Okay, so D, I would have a question about assuring the comfort of the patients. Ventilation is a very hot issue in animal shelters, since there generally is a lack thereof. And I guess depending upon where this content goes, that may be a sticking point for some facilities, because it takes a lot of money, a lot of equipment to properly hygienically ventilate an animal shelter. Certainly anybody can take fans and blow it all over the place, but that's not perhaps the best thing that.
Okay, my understanding, and correct me if I'm wrong, is the definition of the fixed facility would be where the immediate veterinary care is being taken place, which means surgery, reception area, recovery area, period, treatment area, period. Not the whole shelter, correct?
Well, that's, I assume that's originally what the intent was.
Right.
However, when most people come to visit an animal shelter, they go where the animals are, not where the people hang out. And unless ventilation, adequate ventilation, more than just comfort ventilation for the humans is addressed, further on down, I think it needs to be addressed somewhere.
So what do you suggest?
Can I just point out that the definition above is where we know it applies, and it's specifically a building where veterinary medicine, et cetera, is being practiced. So if a shelter has one area of a building where it practices veterinary medicine and a separate area in the same building where the animals are kept but no veterinary medicine is practiced, that entire building would have to comply with the provisions. Or it's a separate building where the adoptions occur in the scenario you brought up.
I'm more confused now than I was. Sorry.
If a shelter provides adoption services and just houses the animals, they would need to do that in a separate building away from a building where veterinary medicine services are provided to the shelter animals because of the definition. It might be something that we just take a look at, but it would be something to consider going forward, because if the building does both, houses and provides veterinary medical services, the entire building would have to be properly ventilated.
Well, that's exactly my point, because most of the certainly the older facilities, it is one building that used to be something else that got converted into an animal shelter. The newer constructions, they use essentially a pod system where there's like one main administrative building, and the animals are housed in different subunits of buildings. And where the medical facility is, or even if they have a spay-neuter clinic, that may be in yet a third different type of structure. So I do think then that we need to clarify on the campus, let's call it the campus motif of an animal shelter, which buildings would fall under the quote animal shelter provisions that we're seeking to adopt here now. Or, carte blanche, any facility on the same plot of ground. I mean, I just represent 4 shelters, you represent 400, so.
Erica Hughes, California Animal Welfare Association. And I think we should go back to the reason we're having this discussion in the first place, and it was to be able to provide necessary care on intake to shelter animals. And while it may be a good idea to regulate animal shelters as a whole, I think we need to ask whether the California Veterinary Medical Board is the appropriate agency to do that, whether it has the resources to do it and whether it has the expertise to do that. And so I'm not saying we're necessarily against regulation. I just don't know that broadening this definition of essentially an animal hospital to include all of the entire shelter makes sense. And it's not how it's been done in practice. My understanding is that when investigators come in, they confine their investigations to the area that's covered under the premises permit, and they're not walking throughout the shelter.
That was also my understanding.
Is that not the case? Is it not the case that when investigators come in, they confine themselves to the premise permitted area?
My understanding is that that is what they do.
Well, I read D as something fairly reasonable, and what I hear Alan say is that it may be too comprehensive of statement to have even existing shelters, your 4 shelters, for example, you might have concerns that they don't abide by that. Is that right?
No, just the opposite, frankly. Our shelters have complete 14 air exchanges per hour.
Okay.
Complete air exchanges. The air on the people side of the cat building, for example, is completely separate from the air that is where the cats are. So there's no smells, there's no aromas, there's no nothing. You wouldn't even know you were in a cat house. So, and my point with this whole thing is that I am thoroughly aware of shelters that have a premise permit for the spay-neuter operation, and you would not want to go into the side of the house, the other house, however you want to describe it, that houses the animals, because there's no ventilation other than an 8-inch fan. And I'll give you another example. There is cross-kennel drainage. So when one pup has parvo, everybody gets exposed to it. Then we can we can look in the newspapers, we had a heat wave here in Southern California some weeks ago, and there was one city-owned shelter that volunteers brought in blocks of ice so that the animals could cool themselves, because it was like 115 degrees. That's acceptable to the Veterinary Medical Board, to the people who actually own those animals, who maybe not know that they're down there already and they haven't come to redeem them?
Bonnie?
Yeah, and I totally understand, what you're saying, but I think that to go back to Erica's point, my understanding of the whole point of even this discussion was to look at shelters and be able to have some minimum standards and then allow RVTs and VAs to perform certain functions. And if we now define the facility as the whole building, despite a perfect world where you would have great ventilation and everything, that simply is not the case in a lot of shelters. I mean, there's a lot of shelters that were just big old buildings, but the animal premises permit area, especially with people that have consulted with me, they've closed it off so that there's a door that goes into it and it's separated for the rest of the kennel, and the animals that are being medically treated are separated, but they're still technically in the same building. So, I mean, I don't know that seems to be an unintended consequence of our doing this, is to have a definition that assumes that this facility is the entire building, because in a lot of these cases, you're talking about a huge government building, and obviously, while it might be a good idea at some point in time to have some agency look at animal shelters, I don't think that was the purpose here, to have the Veterinary Medical Board all of a sudden be responsible for looking at all the sections of a huge animal shelter that might have 300 or 400 animals.
Tara, then Dick.
We've already delayed continued deliberation on the definition of animal shelter facility, so perhaps we could take a look at that separately offline and then bring it back to the committee. But just making sure to take a look at the fact that the current definition says shall mean a building. We could just modify that to aim it directly at the area.
Or part of a building
Right.
where veterinary medicine is, or its various branches are being practiced.
You want to rephrase that and we can nail it down, or?
Well, we're going to be redoing this all, but I've got in that first sentence, animal shelter facility shall mean a building or part of a building where veterinary medicine and its various branches are being practiced.
Okay. F.
Well, D, do you, I think we need to stay with that wording, and
Yeah, no, I'm cool with the wording. I just wanted to make sure we were all on the same page as to what it applied.
yes. E, F, G,
So, I'm sorry, if we could go back to F. I didn't get it quickly enough. A reception area, to me, implies that there is a public that's coming in to get veterinary services at the shelter. And that's not what this is intended to cover, right? I mean, those, animal shelter that has a hospital that's open to the public would just be subject to the regular hospital minimum standards for any other hospital would be subject to, right? This is just for impounded animals, this is for shelter animals, and so I don't see why you would have a reception area for shelter
I
animals.
thought some shelters did public spay and neuters.
But I think if you're doing that, then you are just like a private veterinary hospital that's doing a spay or neuter. I thought we're talking about the narrow the situation in which shelter animals are being treated by shelters.
Well, then, the problem with that, maybe we need some verbiage that says when you are doing public spay and neuters, then this applies. But the problem is if you have a shelter that is doing public spays and neuters and you now throw them into the regular fixed animal, small animal practice, they're not going to get the exemption.
So I think that raises an interesting issue, and an interesting issue because there are shelters that do both, right? They have a
Right.
public clinic and they also treat their own animals. And in that circumstance, is it that they have a dual permit and they're treated one way for, I mean, I don't know how that works.
Well,
I mean, you have that.
I've been inspected a number of times, and I've been inspected in the context of a small animal practice. I was required of everything that a small animal fixed practice was required. And I think that should apply to whether you have a surgical facility or not, because you're practicing veterinary medicine in some other form, you're just not doing surgery. So there are shelters that only spay and neuter their own adopted or redeemed animals. There are, like ours, that we have public bring animals in for surgical services, just spay and neuter. But those that are, in the context of what we've been talking about this morning, those that are treating their impounded animals, they would have to be inspected as well, because they're practicing veterinary medicine there.
Right, but we still want to have your facility have the ability to have the protocols that we're calling out for that exemption in 2035.5.
And that should be whether they do surgery or not.
Correct. So the question here is on F, is should F be there if they're not doing public spays and neuters?
But if they're doing medical treatments pursuant to the direction of a veterinarian or veterinarian on premise, they have to engage the public. I mean, they're not, sanctuaries where the animals never, the Hotel California where they come and never go. There has to be an area to engage potential owners.
But is that reception area part of the premises permit, or is that a reception area that's just the general reception
Part
area
of the
for
shelter?
And
Yeah, hence the discussion.
Yeah.
So the animal shelter facility that does public spays and neuters shall have a reception area and office, or the combination of the two.
Ellen Moon Carveta, as a shelter RVT for many years.
Public
It's completely reasonable for a shelter to have a lobby and reception area with all the appropriate signage like you would in a hospital. It's not a burden. And the shelter's going to be doing business with the public whether or not they offer services to the public. So I think it's quite appropriate for them to have a reception area.
I think I think it's important to make a distinction between a reception area that's part of the general shelter and the shelter in general, and a reception area that's part of the fixed facility that's under the purview of the VMB.
Erica, may I ask, what would be the example of shelter that you found acceptable in every other way but didn't have a reception area?
Oh, I think they all have reception areas, and as Ms. Moon said, because they deal with the public, but whether or not that reception area is part of
Surgery.
the fixed facility is, some may and some may not.
But let's be reasonable and understanding about what the requirement would be, other than the physical reception area. So there's postings, there are licenses that, how much of a burden is that? It's none. But it implies, and not more than implies, it indicates to the public that this is a veterinary facility that is permitted and occupied by permitted licensed personnel.
I think if the clinic is serving the public, like, for example, doing public spay and neuters for publicly owned animals, then yes, it should be operating just like any other premises. If it's doing spay and neuters just for its own impounded animals, then I don't see why it needs a reception area in the way that, in the context of a premises that's overseen by the board.
If I may. There are times in a shelter setting where we pick up an animal and bring the animal in, and we can't find the owner, but are required to give treatment to the animal because it would be humane, whether they have a laceration or they pick up an upper respiratory or whatever. Humane treatment requires that we treat those animals. Now, those animals are sometimes redeemed, and we would need a place, like a reception area or office, to review the medical care that the clients received, even though they didn't come to us for medical care. Their animal got medical care because it was picked up as a stray, and it was humane for us to do so. So I still see the necessity for the reception area.
And that owner, like any other owner, is entitled to see who the license permit holder is and who the veterinarians and RVTs that work in that establishment are, for the same reasons that a small animal practice would be required to provide that information.
Excuse me. Jessica has a point of clarification.
When it comes to a reception area and office, to me, that's not giving an option of the combination. It's not, it can't be either or, because you're saying and, so you have to have, how it's currently written, my interpretation would be you have to have a reception area and an office. The or combination of the two becomes redundant because you have the word and, so if the intent is to do one or the other, I think you should change and to or.
Dick, do you feel it needs both reception area and office?
This was not discussed in any depth it didn't come to the surface when we were putting through. As a matter of fact, I can tell you that it comes from Section 2030, Item B of existing regulations. And that's 2030. So that's existing code for small animal fixed facility.
Okay, so perhaps it means a reception area which is closed off by a door, an office which is closed by a door, or a combination of the two, a reception area that's large enough to also have an office area.
Yes.
I'm trying here.
As long as we're not doing surgery in the reception area, I think it matters. Okay.
Do we need both a reception area and an office?
No. Separately, no.
So perhaps we could change it to reception area or office, period, and strike the or combination of the two.
Well, I understand the way it's read means you have two options. The or means you have two options, but that's English that I'm not very good at, so I'll leave that to others.
Bonnie?
Yeah, just one way maybe to look at this, if we're concerned about the shelters that do provide veterinary treatment for third-party animals, would be to just put some language in there, in this, that says, if shelter or whatever you're defining it as is providing veterinary services to third-party owned animals, they must comply with, and cite the regulations that just, make you comply with a regular vet hospital. I mean, you still got all those regulations that a regular vet hospital has to fall under, and so when I have clients that do spays and neuters or any kind of surgery for third-party animals, then I tell them, you're just like Joe Smith down the street vet office. You have to comply with all those regulations. So if you had some kind of language in here that specifically said that if you're doing that, if you're providing vet services to third-party animals, then you have to comply with all the other regulations.
So my only clarification there would be at the request of the owner, because otherwise all of these animals could be owned. We just don't know who the owner is.
That's a good idea, yeah. Yeah. So, I mean, again, it would be similar to like what San Bernardino Humane does. You know, they do a lot of third-party animal vet services, so, yeah, that's a good idea.
I agree, and I think it would be helpful to shelters that aren't doing surgeries to have 2030.6 really set out what that shelter needs to have and what it needs to do. And I'm thinking of, the small police departments that have, 10 cages or 5 cages, or the small shelters that again aren't doing surgeries. And I think trying to combine it all into 2036 and have it apply to what are really two very different sorts of facilities is confusing.
Well,
Because they already have minimum standards in place. The ones that are serving the public already have minimum standards in place that apply to
Then
them.
how are we, well, let me take a look at this. As we go through this, when we got to the surgery part, it says if the facility is doing surgery, sterile surgery or aseptic surgery, then it must comply with additional conditions. If they're not, they're not. So as I was reading this, I was not differentiating between a reception area for a shelter's general business and a reception area for if they were doing surgery. I wasn't seeing it as two different entities. If we use language like if the shelter does surgery for third party, is that clients? Then you have to, then you fall under 2030.1, because that's what you're saying. So it still is a shelter, so they still qualify for 2035.5? The exemptions for shelter?
With respect to animals.
Okay.
With respect to shelter animals, yes.
All right. I don't have a problem with that. So, we'd say F would fall under, so F is already in 2030.1. So then I'm just trying to think of the schematics here,
So
the format.
I'm wondering if part of the definition to be determined later could incorporate the provision that shelters, a facility operated by a shelter that provides spay and neuter services for clients at a client's request should comply with 2030.1. So we're saying those facilities don't fall under these requirements. They fall under the standard requirements. So it then completely takes out public requested medical services.
But I think you also want a spay-neuter facility that's only serving shelter animals to comply with the standards that any other hospital has to comply with. So to me, it's not about whether it's public or not public so much as it is what's being done in the facility. And so if surgery is being performed, any place where surgery is being performed should have to comply with the same minimum standards. But that if it's a facility where you don't have surgery being performed at all for a shelter animal or a publicly owned animal at the public's request, then you have 2036 to speak to that situation and set forth minimum standards that make sense for that kind of setting, like a police station that has some kennels in it, or a small shelter
But-
that isn't doing surgeries.
Wouldn't the police station where you go in, wouldn't that be the reception area? And wouldn't they have to have the notification of, or the display of the veterinarian's license there? That's got to,
So I'm actually, I was speaking more globally, not just F, but kind of the overall structure and purpose of 2030.6 would be to address that situation. And in terms of the reception area, I mean, I still think it's an important point that there's a difference between a reception area for the shelter or the police department and a reception area for the public seeking veterinary services.
I guess as we toss this around more and more, I'm not sure I see a difference. So I think we need to hear from other board members rather than me. In other words, I think that any of those shelters that we're thinking of could accommodate this condition. We're not asking them to have two different reception areas, are we?
I think we're trying to determine whether or not the reception area is even necessary if no client is arriving to discuss the care of the animal. And if a client is arriving to discuss the care of the animal, that's a permitted premises that is already required to comply with the other minimum standards.
So if the premises is not doing surgery, but they are doing veterinary medicine and they have a premise permit, where do they display their license? Their premises permit license and their veterinary licenses?
Wouldn't that be under 2030.1? They would be complying with the minimum standards that way? Because as long as they have a premises permit, because they are providing veterinary medical services, then they have to comply with the minimum standards anyway. This should be all about just those veterinary services provided to animals that the client is unknown. There's no known client. We just have an animal patient. So some of these provisions, like a reception area, may not be necessary as a requirement for the shelter. You know, I'm also looking at subdivision O. When the facility is closed, a sign shall be posted and visible outside the primary entrance with a telephone number and location where emergency care is available. Is that necessary for this situation where there's no client?
Yeah, well, I threw that out, and Jennifer said it needs to be there because people do come in after hours and need to know where an emergency clinic is.
Absolutely.
Is that because they found a stray? Or is that their own personal owned animal?
Or it's an animal that they adopted from us that they think has a problem 3 days later. And I can understand the philosophical discussion here, but how much extra effort is it to put up a sign or two and a license or two behind a reception desk?
Well, I think the point is trying to draw a very clear line between a shelter providing veterinary medical services to unknown owned animals versus a shelter providing veterinary services to clients and their animal patients.
I don't see any difference at
There's
all.
no difference at all.
Okay, because
In my experience, as a shelter RVT, those unknown animals have owners, and oftentimes they come in, we just don't know it at the time. So I don't see a difference between the two. I mean, it's perfectly reasonable to have the reception area with the licenses posted. People do come to us with the assumption that they can get care, even if we may not provide care. And we still have to provide them with information where they can seek help when we're closed.
I'm starting to wonder if the shelter,
Sanity here.
well, I may be sending us down a different rabbit hole, and hopefully I can just toss this out there and you can just put the kibosh on it quickly. But if the facility providing medical services to unknown animal patients, that facility is the same and potentially should be registered as a premises and have the same requirements as any other premises. Should we have instead just created the delegated functions exemptions for shelters rather than create a whole new minimum standards for animal shelters providing medical services? Shouldn't they just be following the minimum standards for every other facility providing veterinary medical services? Because the exemption is not in here. The exemption is under 2030.5 in the delegated tasks.
Well, I have no problem with that. The exercise that we're doing both in 2030.6 and 2030.7 is to see if we actually even need them. So the idea of going line by line is to convince this board that, yes, we do need them, or no, we don't. And, and right now, we're stuck on F. So if we go through this whole list and we accept them, then, we took this from 2030.1. So that exercise could lead us right back to there and say, we don't need this section. But I didn't know that. I thought there are things in here that are unique, that shelters don't need. And I think this is the exercise to find that out or not. If we go through the whole thing and every one of these items is the same as 2030.1, then we don't need it. But if there are items here that are uniquely need to be eliminated from 2030.1, then we need this, if that makes any sense.
Bonnie?
So I'm hearing from,
Excuse me.
The only concern I have, and again, because I end up defending people, is that since now we're looking at all these other minimum standards for other kinds of practices, small animal fixed, house call, mobile, large equine, small equine, all of that, my only concern will be then that the animal shelter practices sort of fall through the cracks. So since if we're going to go forward with all of these minimum standards for these other types of practices, I think we probably should have one for animal shelters. Now, that having been said, if we go through this whole exercise and you all determine that what's required at an animal shelter is the same thing that's required under 2030.1, couldn't you just have this definition that we're going to work on and then say those facilities need to comply with all the specifics in 2030.1 and not have to list it all if you do determine they're the same. But at least that way there wouldn't be that loophole for people to say, well, we're really like an equine ambulatory practice, or, we're more like this or we're more like that. It would clarify what they are.
Erica?
So this conversation started in response to the concern that a veterinarian in the community with a separate hospital who sees private clients is hesitant to be on a premises permit at a shelter location where the veterinarian doesn't exist there on a daily basis, and there are no other veterinarians working there. They don't have any, again, like we've talked about before, they don't have any control over the hiring and the firing or how things are run in the shelter setting. And so the idea was to do something that would kind of limit the liability of the veterinarian, the community veterinarian, to make it more attractive to be on a premises permit at a shelter. That was one of the purposes. And the other one was to have regulations that if you're a shelter, you read them and they make sense. They're written for a shelter. They speak to the unique circumstances of a shelter. And it doesn't mean that it's going to be a lower standard of care for the animals in the shelter. It just means that there wouldn't be things like, for example, N says, if animals are housed or retained for treatment. Well, I mean, just by definition, it's a shelter. They're being housed and retained. So if you're an animal shelter, you read this and then you have to be like, well, okay, that would apply to me, but that doesn't really apply to me. But this one obviously is contemplating a regular private hospital. But this one, I don't know, I guess this one applies to me as a shelter. And so I thought what we were trying to do was get something that is for shelters and tailored to shelters and speaks to shelters, and that every provision in there would make sense for a shelter. And this, what I'm seeing here, a lot of it just is not necessarily applicable.
So does that mean you support a separate regulation aimed directly at shelters? And as Dr. Sullivan has mentioned, we're going through each one line by line to figure out whether or not these should apply in an animal shelter situation. I mean, I know that I hear disappointment in that these look the same as 2031, but I think that was the idea. We just were walking through to make sure, is this necessary? If it's not, let's strike it out. So do you think we need the separate reg? And which of these do you think should be taken out?
So I would like to engage in the process of going through one by one and hearing the discussion. I mean, I have things that I've flagged, but just like the one for, an ambulatory practice or the one for a vaccine clinic, those look like they were written for those particular settings. This one doesn't look like it was written for an animal shelter setting. And I think that's important. And it's important so that people can comply.
Right.
And instead of having to interpret.
And this is the exercise to get us there.
Yeah.
So why don't you stay there? Not that I want to put you on the spot, but.
Okay.
So do we have a consensus on F?
Yeah. Erica, any objections on F?
I don't feel strongly about F.
Okay. G.
G.
So again, that we have the term client. So if I'm an animal shelter and I only, and I don't have, there are no clients there, it says the doctor, assistant, patient, and client. Maybe it should say a doctor. I don't know why client would be there at all.
That was going to be my issue as well. I mean, under the discussion about a spay-neuter clinic that sees public animals, certainly, but for a regular animal shelter situation, we have no clients.
Okay, should it say the animal shelter facility shall have an examination room separate from other areas of the facility, period? In other words, what we're saying is you can't have the exam room in the surgery room.
Could you examine?
Well, you couldn't have that from the surgical perspective.
Yeah, that's
So you
right.
can't argue the other way around, but
Correct.
should you have an examination room separate from the sally port where the trucks are unloaded?
Or do you need a separate exam room?
Yes, you do.
Okay, then I'd say period after there.
So, Dr. Drees, in your opinion, it wouldn't be acceptable to examine an animal?
A what?
At in the kennel, do an exam there?
No.
With 40 other dogs barking up a storm? With the poor ventilation that we've already described?
Bad lighting?
Poor lighting, exactly, thank you.
Okay.
You're trying to hear that heart murmur, right? And you got 40 dogs barking?
So if we make it the animal shelter facility shall have an examination room separate from other areas of facility, as Dr. Sullivan just said. Okay? H.
And we're interpreting this means it could be a cell phone with a plums on it. I mean, we have to have resources readily available, especially if there's an animal that's crashing on us.
So with those, I think in a common scenario, a veterinarian's only going to come and visit occasionally or as is necessary to maintain the standard of care. But are these materials for the veterinary assistants and the RVTs that are in the shelter, who are in the
No,
shelter?
it's for the veterinarian. For
But
the
if the
practice of veterinary medicine.
So if the veterinarian is on the premises permit but doesn't reside at the shelter, is in town in his or her hospital.
We're copying this after, let's say, an ambulatory veterinarian. They have to have resources available with them.
In the
Yeah, it might be
Yeah,
all.
Merck's manual on the dashboard. That worked for me for years.
That makes sense.
Plum formulary.
Okay. Aye.
Aye.
Jay?
What does it mean to have the ability to provide diagnostic radiological services?
There's a clinic nearby that you can refer to. Now, this is, I'm hoping that this intent is also being captured because we want to make sure that the inspectors are getting the intent of this. Okay. Where are we?
Okay.
K. Same thing. Be able to refer it out if necessary. L.
So who can provide emergency care? Just the,
RVT.
so if there is no RVT at the shelter, does it still have to have the equipment needed to provide immediate emergency care?
If they're providing veterinary medicine, I would say yes.
But there might be a veterinarian who comes during an emergency, they're made, okay. Okay. Yeah, that makes sense.
Are we okay with that one? Okay. M? Okay. N?
This is my big one.
Okay. Go.
Separation of animals and waste products. There are many shelters out there with thoroughly inadequate housing.
If it's in the section of where the practice of veterinary medicine is,
That typifies the philosophical distinction between how you look at this and how I look at it, and how what the public's perception of the actions of the Veterinary Medical Board may be relative to an animal shelter. Because an animal shelter, by definition, is a place that shelters animals. Shouldn't make them sick, should provide adequate care.
Okay.
And if it's got a premise permit, that would include where the animals are housed, or how they're housed.
So you don't.
I've been to shelters where rabbits have been stacked in cages upon each other, so they crap on everybody below them.
So you think this isn't sufficient, or it is?
If we're separating, the question was whether this is sufficient or not. Yes, in one context, it certainly is sufficient, but in the context that we're only going to look at that place where either surgery is done or medicine is practiced, not where the animals spend virtually 24 hours a day. And they're lucky if a person comes by once a day to clean them up and feed them.
Alan, where it says the animals are retained for treatment.
They're all,
Oh, sorry.
they're all retained.
Then there you go.
They're not there voluntarily.
So if it's where they're retained, then doesn't this apply to the whole hospital?
With all due respect, I'll argue for Dr. Sullivan, saying that that's not part of what the inspection process or the permitting process should be if it's not directly connected with the medical or surgical management of those patients, of those animals. I'm saying that it has to extend to that area of the building or those buildings where the animals virtually spend 24 hours a day. There's another thing in here later on about getting them out and exercising them. That's all great, but when you got 400 dogs, 80 of which you wouldn't trust with a 3-year-old, and you're supposed to take them out every day and exercise them, give me a break.
I don't think that's our purview. That may be Erica's purview, but not ours.
I'm concerned about the use of the term housed in subdivision N. I think this could be construed to mean if they're housed. It doesn't necessarily flow that somebody's going to see that housed for treatment as part of that phrase. It's housed or retained for treatment. So I'm suggesting that perhaps we could just strike housed or, because as we know, this is the shelter and they're being housed somewhere on the property, but perhaps they're just retained in the animal shelter facility for treatment.
So like in the hospital.
So we
in the medical
separate,
ward.
yep, we're separating the medical ward from the housing unit where no veterinary medical services are provided. I just want to be clear that this is not about the other side of the facility. This is, once again, just aimed at medical practice.
But the dog that was healthy when it came in the other side of the house, 2 days later, it's not healthy, and it's in the hospital side of the house. I don't understand the difference, and I don't understand how the public is being served by veterinary medicine to permit that dog to become ill in that side of the house, and the VMB only care about it when it transitions to the hospital setting.
If you want us to do inspection of all of the shelters, then propose that as a motion. But I don't want to go there because we've got enough to tackle here.
I understand, and that was never my desire. My desire is to bring some semblance of order to the chaos that is an animal shelter.
I'm going to propose that we bring some semblance of order to the topic because we're not going to get through this. Actually, we're not going to get through any more of this because we're going to move on. I think the best means is to take what Tara, legal, and Dr. Sullivan have started.
And Jennifer.
Excuse me. And kind of sum up what we've concluded, what we have concluded so far today. Bring this back to a line item at the next meeting. And the main reason is because there are a couple of other items on the agenda that I do want to get to. Work has been done on, and they're also not going to get finished today, just FYI. So if we don't get them started, they won't get on the agenda the next time. So are we okay moving on? It's 2:30?
Yep.
All right.
Sure.
Thank you, Erica.
Agenda item number 7, minimum standards and protocols for dental radiography, procedures, potential recommendations to the full board. This is a subcommittee of me and Leah. In the packet, I would just like to, and anybody who doesn't know, there are packets over at on the table next to the door. There are a couple of items in the packet that I think are important to just recognize. We don't have to discuss everything on there, but the first couple pages is just a discussion of the issues. I want to put some definitions out there, make sure everybody is speaking the same language. Included are some guidelines AHA has put out 5 years ago, and the newsletter for the AVMA's Professional Licensing Insurance Trust, PLIT, has a summer 2015 issue where several dental cases have been adjudicated. And then the last item in the packet includes the statement from the Dental College about dental radiographs. So what I'd like to do is just start by saying that this subcommittee was formed when, after the last meeting's discussion of RVT dental extractions was presented by Dr. Klingborg to the VMB, it morphed into a question about dental x-rays or radiographs. Dr. Klingborg pointed out that wasn't the task of the previous subcommittee and wasn't discussed, so it was voted on at the VMB to send it to the MDC, so here we are. So we're looking today into making intraoral dental radiographs a requirement in the practice of veterinary dentistry, which means we want to talk about, discuss, decide, vote, whatever we decide to do today, on whether taking intraoral dental radiographs under anesthesia should be required as a standard of care practice. And I think in my talks with veterinarians and RVTs who do dentistry, and I'm going to have Leah weigh in also on this particular topic, I think there's either confusion and or outright disagreement about what the term standard of care means. And I'm going to have Tara weigh in here if I say something way off the reservation. But I put in here a paragraph that is, in some measure, I think, what I understand the standard of care to be. And the line, standard of care is determined by expert testimony during trial as to what a reasonable, prudent doctor would do in the same or similar circumstances. I think all of those words are important. I think the discussion about standard of care in the context of geography, board certification, minimum standards, they all have some connection. They're not all the same thing. And I would hope that whatever we decide to do on the topic, we at least make sure that we all leave here knowing today what a dental x-ray is and what standard of care in the context of dental radiography is. Let me ask Leah, who we both work in very different ambience, as do, this is a good group because we have a selection of people who, some of whom probably do dental x-rays or at least dentistry every day, some of whom probably haven't done it for a long time. So let me break for a moment and ask Leah to weigh in on what your thoughts are on the issue.
Sure. So I've worked in a number of practices, as Dr. Pollard referenced, emergency, day practice, some food animal when I was in school, now do specialty care. So it's been a number of years since I did dentals and x-rays for dentals myself, but I did kind of take a straw poll talked to a bunch of different veterinarians that I know, and I found exactly what Dr. Pollard just said, is that really the feelings are all over the board of what necessarily should be done and what is being done. So most of the doctors I talk to do offer dental radiographs. A few don't have the service at all. From there, we get to groups of people that either have it as a standard with their packages to take full mouth radiographs. Others leave it as an option up to the client whether to do it or not. And still another group would say they do them if indicated after an extraction, something like that. So, Dr. Pollard put together a whole bunch of resources. Some of it I found interesting as well, of the insurance take of it and all those kind of things. But I think as we look at this, that's all kind of from my San Diego area of veterinary practices, which I do believe probably have even more of this going on than other areas. So I think it's kind of all over the place. That's my take on it for the moment.
Under the issues paragraph there, we listed just a couple of statements that refer to parts of the problem. I made reference to the estimated number of general veterinary practices that offer dental radiographs, and I stand by the statement, unknown and varies by geography. The 30% part of that statement, I will confess, was pulled completely out of the air. And it's largely because I don't think we know, even in a subset of California, what that number is. This discussion has been had both at the individual practice level, the fact that I, doing relief work in practices that have dental x-ray RVTs that are involved in the COHAT, I don't think is very informative for the topic because that's just too small a population. I'm more interested in getting better acquainted with what the whole of the profession does, and if we could discuss as a committee, and then I want to hear some public comment about what the pros and cons and how each of us view the need, the requirement, the good idea version of whether dental radiographs should be standard of care, however you interpret that. Who here has done a dental x-ray in their life?
We've incorporated them into our practice. We've incorporated it into our practice. We do a full set of radiographs on every dental patient. Before and after the teeth are extracted, we take a specific one of those as well. That is our standard of care. Whether that should be the standard of care throughout the profession, I don't know, but I do think it is a standard we should, aspire to.
Meg?
I would wholeheartedly agree with Kevin. I think that once you start taking radiographs and you understand what you weren't seeing and what was potentially being left untreated without the radiographs. So again, whether or not it's something that is going to be the minimum standard of care, I'm new enough to this that I'm not going to say that we have to set that as a minimum standard, but definitely would be a recommended standard of care.
Dr. Sullivan, what do you think?
I didn't think you were going to look down this way, good. I guess I look at this totally differently. Lived through maybe 24 years of non-anesthetic teeth cleaning where we were fighting tooth and nail to get that under control. And I think if we go this direction, we will just give more ammunition for that area to reopen. That's my biggest concern. A second concern I have, our clientele is middle class and lower middle class, and I think if this becomes a requirement, I think we're going to eliminate the ability of lower income people to afford this service. And I'm very conscious of that. We have digital equipment that we are using more and more. I'm not saying that Dr. Waterhouse twisted my arm into this, but she did convince me that we should go that direction. We've been doing it for a few years now, and it is what we should all aspire to. But I think there's always those unintended consequences, and I'm really concerned about the people that we would be shutting off from affording the ability to have basic dental work done if we require this as a minimum standard.
So, segueing off of that, what does the committee think about, in this case, dental x-rays? You could use ultrasound, you could use thoracic radiographs, you could use a CBC machine, pick your test or your diagnostic. Whatever that estimated number is of the number of veterinary practices or the percentage of them that have dental radiographs, it's probably not very high. It's probably getting higher than it was 24 years ago, but the 30% came from a discussion that I followed on VIN where a practitioner made the argument. He happens to work in a very large area of Texas. He works in Houston. And he said that when he came to town in 1982, not all people had capacity to do radiographs of abdomen and thorax. And at a certain point in the ensuing 40 years, I expect Texas is similar to California. You have to be able to do an x-ray in your practice or have the capacity to farm it out. Dental x-rays, he claims, are 30% of the practices in his area. And his argument is, how can one make standard of care, which I want to make sure everybody understands, how can you make that standard of care if 70% of the people don't have it, don't do it? And standard of care, Tara, please weigh in, means if you don't do, in this case, dental radiographs, have the capacity to do them, you are committing negligent or incompetent act.
Right, that would be the application of the standard of care analysis, is when there's an allegation of incompetence or negligence. So right now, you only revert really to standard of care because it's not written. It's not laid out in statute or regulation. So then you start to rely on expert testimony to describe best practice, what people in the area understand with respect to that type of treatment and what is proper treatment and what is improper treatment. So if we're talking about standard of care, in this context, it's solely aimed at negligence and incompetence because it's not otherwise delineated in your Practice Act. But if you decide to put something in regulation and require certain procedures to be performed for associated with certain diagnoses, the standard of care becomes very clear, and you no longer have to describe what it is.
So as an example, I've talked with a couple of people earlier today about this. Cherry eye is referred to as a prolapsed third eyelid gland. And 20 years ago, the treatment for cherry eyes, classic is a beagle, seems to be a beagle always, basset hound, puppy with this big red tumor-looking thing in the corner of its eye. And the common practice was to surgically cut it out. And cosmetically, it looks great. But in a large percentage of those patients, we have set them up for a condition where they have lack of tear production, KCS. So now, 20 years later, it's not written anywhere. It's never going to be written anywhere because the standard of care isn't written anywhere. But if a veterinarian cuts a third eyelid gland off today and a complaint is filed and it goes to PLIT like demonstrated in that newsletter, I will bet that that veterinarian will be found to be practicing below the standard of care. Why? Because the majority of practitioners in that geographic area, level of care, whatever the parameters are, don't cut them out. At a certain point, I think most of us would probably predict that dental x-rays are going to become standard of care. It's just the nature of practice and advancement of science. And I say that because I haven't come across anybody who has claimed that medically it's not indicated. Medically, it's a bad idea to take an x-ray. The complaints, not the complaints, but the cautions are in the cons section there, where people indicate for financial reasons, for training issues, for time constraints, for limited access to clients and subsequently their pets that may not get care if it were required. Those are the reasons that are raised. I've yet to come across somebody who's made a cogent argument for dental x-rays being a bad idea for the pet. So there, I think, are strong feelings and good arguments and some not so good arguments on both sides of the issue. But I think it's relatively important, I think it's very important, that just to make a statement that dental x-rays should be standard of care really encompasses more than perhaps what one intends if you look at all of the factors involved. If at some level dental radiographs are made standard of care, should they be of the whole mouth? Dr. Lazarchev just mentioned, should they be of the whole mouth every time the animal gets a dental cleaning? Should they be before extractions, after extractions, always in cats, only if the owner can pay for it? I didn't even get to waivers. I'll defer to audience comment. But the reality is the veterinarian cannot solicit the owner to sign off on negligent care, however, whatever the negligent care is and whatever the level is deemed. So let me ask if there's any comments at the moment from the committee.
I just had a question with the regards to standard of care being best practice. When that comes from an expert witness, what would an expert witness in a dentistry case be? Would that be a boarded dentist?
Good question. My answer, I hope, is the answer, but my answer would be back to standard of care. You are judged by your peers. And although I and you and Bill Grant I don't remember any cases in the 100 or so that we've read involved dental issues, but I'm sure they will. In fact, I'm certain they will now, that it's raised to the level of discussion at the MDC and the VMB. I think there would be an expert. I don't know if it would be a dentist, a boarded dentist. So a veterinarian board certified in dentistry restricts his or her practice to that. I would like to think that the act upon which the complaint was based would be judged like all other standard of care issues are judged, among and by and compared to other people who do the same kind of practice, same level of care in that area of the world. So one other thing I'll touch on to your question is best practice, gold standard, standard of care, minimum standards. Those terms are thrown around, I think, with not a lot of common understanding. My answer to the question about the expert witness when we review these cases is that's the person who has to evaluate the case, evaluate the conduct, and make a determination, and then defend that argument at hearing, should it go there, and has to recognize that there's another expert on the other side who's going to have a contrary opinion. So right and wrong is not necessarily the best parameter here, but for my 2 cents, I equate minimum standards as a standard of care, because I don't think you can offer your client substandard care and get away with it. I think there's a big difference between offering what would be reasonable, good practice, however you want to call it, and doing more than that. Specialists, board certified in internal medicine, cardiology, whatever, are held to a level of practice that other specialists in their field are held to. Veterinarians who do general practice, I don't believe are, nor do I think they should be expected to be held to that level of care. Having said all of that, back to dentistry. At this level of veterinary medicine, meaning in 2018, I would say most practices that I'm familiar with have a dental cleaning unit and offer some level of dental care. I would say most, as has been discussed, don't have dental x-rays. If you read the details of the PLIT newsletters, the gist is there were 3 cases. The veterinarians did extractions on all 3. One of them had 2 separate dental events separated by 16 months. 2 of the 3 cases had mandibular fractures caused by the dental work. And all 3 of the cases were concluded to be below the standard of care. Why? Because an attorney at PLIT said we're going to lose at hearing. If this goes to a lawsuit or this goes to a board complaint, we're going to lose. I think it behooves us, excuse me, as veterinarians to think about the concept of who controls our work. You go to work every day, you get up, you do A, B, C in room number 1 and X, Y, Z in room number 2. And in this case, if we punt the issue of, in this case, dental x-rays, standard of care, somebody else eventually is going to determine this. As was demonstrated in those PLIT cases, which are 3 years ago, an attorney for an insurance company said a veterinarian is practicing poor care, not another veterinarian, which I would like to think should be the case. I would like to think that the profession would recognize that there's a standard of care, whatever it is, and however it's determined and however long it takes to get there. I think if we don't police ourselves, so to speak, the Veterinary Medical Board, the PLIT attorneys, lawsuits are going to help us improve our practice.
The only clarification I think is necessary here is that PLIT is concerned about malpractice. The board and the committee are concerned about practice of veterinary medicine on animals and protecting consumers, not how much the insurance company is going to have to pay out on the malpractice claim, because that's a separate civil tort action. So it's different. You don't have to worry about what the insurance company is going to do with respect to an administrative case, because that's just the board saying you screwed up. So you will face disciplinary consequences. not anything to do with your insurer. However, the insurer will most likely rely on a board decision to determine what the standard of care should have been. And when that administrative decision comes out poorly against the licensee, that's when they start settling cases. So I think we need to be careful about the consideration of who's holding your destiny in your own hands, you know? But also, in this type of situation, because there are so many considerations, many of which involve public access to proper veterinary care, perhaps it should be a standard of care issue that's left undefined to make sure that each case is looked at properly in terms of the client, the animal patient, and the veterinarian's expertise and diagnosis. Because what I'm thinking of is every piece of veterinary practice. You don't have standards of care for each different kind of veterinary practice. If there was a significant problem, that would come out with regulation. But the regulations are left somewhat broad and lack specific detail on the steps necessary for each type of procedure for a reason, because each case is different. I just wanted to get that out there for your consideration.
Comments from the public?
Okay, first of all, PLIT. Tara's absolutely right. It's not really the attorney that makes the decision. PLIT has veterinarians. They review the cases. It's unlike other insurance companies, so I know most of those veterinarians really well. They review the cases. Then they talk to their attorney, and they decide how much they're going to settle the case for based on what the veterinarians find. So while the attorney's involved, it's really the veterinarian on the PLIT who makes the determination that this conduct was below the standard of care, and they make that determination. So it's unlike when I handle cases for other insurance companies, there's nothing like the PLIT. So I get the case, and I look at it, and I send it to an expert, and the other side has an expert, and then we decide what we're going to do with it. But the PLIT just has a really different way that they do stuff, and that's how they do it. And they settle. They're very risk averse because their insurance carrier is Zurich, who is notoriously risk averse. So they do tend to settle a lot of cases. So I don't really put a lot of stock in what the PLIT does and doesn't do because they are risk averse. To go back to standard of care it's a minimum standard of care. It's not the best care. So when I went to law school, I had a professor who called it the doctor do-do rule. It's what doctors do. And it's not usually written, and it's not usually imposed by a regulatory board. It's usually what doctors do. So when I started doing veterinary defense, pain medication pre and post-surgery, nobody was doing it except really exotic surgeries. But for spay, nobody was even concerned about doing pre and post pain medication. Well, now you all know that's pretty much standard of care, that you have to give that pre and post. So things happen over time as certain anesthetics become not used so much. I get a lot of cases where I've got some older veterinarian still using an old anesthetic, and the board dings him because that's not standard of care to use Tilazol by itself anymore, okay? So those are just some examples. So I really hope that you will look really hard at not imposing a standard of care, because I don't really think that is the position of a government agency, to impose a written standard of care, especially when you know that if it's true that 70% of the people, the vets, don't use intraoral x-rays, then how can you possibly call that a standard of care? Because it's not what doctors do. It would be you, the board, imposing a standard of care. Now, as time goes on and more people do use intraoral x-rays or whatever type they use, and maybe the equipment becomes cheaper or more people have it, and then it allows access to more people, but you're always pushing this need for dentals. So it's a total shoot yourself in the foot if you start imposing a standard where intraoral x-rays are standard of care. Now, people aren't going to be able to have their animals' teeth cleaned. Now, as far as the consent issue, a client cannot consent to substandard care. So this happens with the spays and the pre and post pain medication. I have clients who say, my client base will not pay for, pre-medication for pain for spay surgery on a healthy young dog. And so, I don't charge it. And I say, well, if you get caught and you have a complaint and the board gets you, they're going to say that you were operating below the standard of care because you've got to give pre and post pain medication. So, I really hate to see that happen with these intraoral x-rays, because that will leave so many people not having their pets' teeth cleaned. Because what are you going to do if you have a client come in who says, I'm not going to pay for intraoral x-rays, I just want to have my cat's teeth cleaned? You're going to say, see you later? Or are you going to clean the cat's teeth? What are you going to do? What's the ethical obligation? Send him down the street to your friend? We'll send him down there, he doesn't care, or whatever.
So there's a real answer to that question, and it varies with whom you speak with, and it varies with all those things that standard of care varies by. Most of all, it varies with who you ask and what their comfort level is with doing a procedure that they might otherwise not do. And just like you reiterated, you can't waive negligent care. So the best answer to that question is simply, I won't do this whole mouth extraction on this cat without dental x-rays. That's the best answer.
But I'm just giving, my question is really, do you really want to impose a standard of care where you know that that's going to probably result in less pets having their teeth cleaned? Because I think you pretty much know that. As far as experts, I don't know how many of you know, I did have a hearing where this was a major issue. It did come up, but the expert was a boarded surgeon, and a boarded dental surgeon, and those people are allowed to testify regarding a generalist because they're supposed to be able to distinguish the difference between their standard of care and the generalist standard of care. Well, I always try to ding those experts when they are designated by the DAGs, because I don't think that they can do that. I think if you're a boarded specialist, I think it's very hard for you to also be able to testify regarding what is the standard of care of a generalist. Now, a generalist can't testify as to the standard of care of a specialist. But in my particular case, the judge allowed the specialist, who was Stephen Holdstrom, if anybody knows him, he was the person who testified, and he testified unequivocally that nobody should be doing, dentals without x-rays. Well, of course, he's a specialist. So that's really how it works in practice, just to sort of clear that up. But based on my experience, I really strongly hope that you don't consider imposing a standard of care when really the standard of care is supposed to evolve over time, and it's supposed to be what doctors actually do. And for those of you that are doing it, that's great, but for those people who don't have the ability to do it or don't have clients that are going to pay for it, it would really cause a major issue. And then I'd be defending lots of veterinarians who were doing dentals without x-rays. So.
Bonnie, real quick question. So when you were saying you can't deny negligent care, which I understand, I believe, I just want a clarification. So say you are going to do whole mouth extractions like Dr. Pollard's example, and the owner said, I will not pay for x-rays, so you cannot have them decline that on a treatment estimate, sign off, and that's not...
No.
That's
it
not
might
good enough.
work in a court of law in a civil case.
Okay.
It will not work with the board.
Okay.
You can't, because if the board determines that it's conduct below the standard of care, then it's conduct below the standard of care. And no AMAs or owner declines or anything like it's great to have that in your record because then you have a complete record, but it's not going to save you from, and because I have these spays all the time, where it's got an initial that says owner declined pre and post pain medication. And it does me no good whatsoever against the Veterinary Medical Board when their expert has determined that that was below the standard of care. So, in civil court, it would be different because you'd have a judge looking at the big picture.
That's a waiver. What Leah just asked about is termed a
Well,
waiver.
it's a waiver or an AMA, like a lot of people call it, against
As opposed to an
medical advice.
authorization to anesthetize your pet or
Right, exactly.
do
But,
something.
really, waivers, declines, owner declined. It's great for your medical record to make the argument, but it doesn't save you. It really doesn't. So, people think it does, but it doesn't in reality.
Ken?
So while I agree that intraoral radiographs should be something we should all aspire to, I just don't see how, in the real world, that is completely practical. As there are many things that ideally we should aspire to. Any pet with a urinary tract infection or suspected urinary tract infection or cystitis, should we be ultrasounding the bladder? Any coughing dog, should we be radiographing the thorax? Do we do that every single time? Would we be best? Is there any indication not to do those things? I can't see not, but do we do it every single time? As Tara pointed out, we don't have standards of care set for all the different aspects that we practice in veterinary medicine. And that's a dangerous precedent to set and a very slippery road that we could go down, setting standard of care on everything that we do. As Jeff pointed out in the writing there, that the standard of care is a movable, this is a moving target. And as it moves, yes, these targets are, moving up or getting smaller, and we're getting better. And over time, we will get there. And there are things that it probably should be standard of care for. But for every dental that's out there, I'd say not. As far as I know, I think in a small animal facility, we are required to have the ability to provide radiographs. Doesn't mean we need to have an X-ray unit in the hospital. We can send them out somewhere. So for general radiographs, we don't have to have it, but now we're talking about having to have it for providing dentistry. And not all cases absolutely need it. And we make that determination on a day-to-day basis when that patient comes in and they're having some straining urinating. Do we always jump to that ultrasound? Now, if they have blood and there are other indications, maybe we do require that, but we don't every single time. There are times that we absolutely should be necessitating doing intraoral radiographs, but for every time. So, even before we consider it standard of care to provide, I think the first step would be maybe having the ability to provide. Then if everybody had the ability to provide and they had it in their hospitals, they would start using them more and using them more appropriately. But to require it as the standard of care every single time, that's going to increase the cost by probably a minimum of $200, at least $100, $150 per, and then increasing the length of time. So you're talking about at least an extra half an hour probably to get all this stuff done. Maybe the good dental assistants and technicians can do it in 15 minutes, but that costs time, and so that's going to need to be charged. We're going to be taking away this ability for certain clients to be able to pay for these services. So yes, it's something to aspire to. Is it realistic and practical at this point? I don't see where it is. It's something we need to have in our arsenal, and we need to be using it more, and that's the education that needs to be getting out there, and maybe having the ability to provide that service. But having to provide that service, where else is it dictated that we have to provide that certain type of service or that certain diagnostic? Do we do a CBC on every single patient that has a temperature over 102? That's what we're talking about, getting a dictating standard of cares like that.
Question, Ken?
Yes.
So you brought up a very good comparison, the ability to do radiographs. Dr. Waterhouse and I were talking about this at the break. At a certain point, pick a time, this Ethan being the 125th anniversary, I would be curious to know how far back in the timeline thoracic abdominal radiographs were required. But I'll bet you it's 40, 50 years ago. The difference, even in that, and the regulation does state we have to have, as you paraphrased, the ability, the capacity to do radiographs. Maybe we could conclude on some level that that includes dental. But the huge difference in this issue is the patient's under anesthesia. So the choice is either he's by definition going to undergo 2 anesthetic procedures, planned or otherwise. And there are some dental practitioners who do that. They literally plan that. And my statement is not a value judgment on that. But as you elencate, all those things you just said are on the screen there. Increased cost, decreased lack of care. The one difference I'd point out is that the dental rads are different than regular rads. And you're right, we shouldn't aspire to get written standard of care rules written about dental x-rays or anything else. But I think it's been, I'm very pleased with some of the comments Bonnie, Tara, Dick have made. At some point, like I go back to the comment I made about, I've yet to come across a practitioner arguing against it, meaning it's a bad thing for medical, surgical reasons.
Have you come across a practitioner that argues that doing an ultrasound on any suspected cystitis case is a bad medical idea?
Perfect example.
So, and I think there are different standard of cares for different levels of dental disease. And I think it's appropriate that they be adjudicated as such. So you have that toy dog with grade 3 to 4 periodontal disease. That one that you know is going to have full mouth or near full mouth extractions. That one requires dental radiographs. And if you can't provide that, then you should not provide that, and you should refer that out to someone who can. And that could be considered substandard of care.
Well said.
And so, that's where it comes down to that line, that's where we make those professional decisions every single day, what I can and can't do. And yes, you shouldn't put that patient under anesthesia knowing that it's going to need it and you're not going to be able to provide it. You get in there and you find something you didn't realize, well, that's not on you. We've all been in surgery and gotten into a situation that realized maybe this is a little more than I should have done, and a number of veterinarians have closed them up and said, I need to get a specialist in to do this.
And that's a perfect example, and I want to touch on that. It hasn't been mentioned. You, me, the practitioner who gets into that dentistry or gets into that orthopedic surgery and recognizes he or she is in over their head, it is an appropriate ending to that event to close up the incision and refer it, or get somebody in that is more qualified. The key difference, though, is the client, and certainly the pet, is not in a position to be weighing in on that. They depend on us. So it really is the veterinarian that has to be depended upon to make that professional judgment, and the reality is, I don't think that's happening across the board, at least not enough.
Well, perhaps not, and that's where the education needs to come in, and this needs to be, more of an issue and discussion. But, to set it as a standard of care, I think is overshooting the target.
Thank you. Dick?
Well, I have trouble with this discussion right along the lines. So the client that comes in that has a severe dental problem, and it's a 5-pound Chihuahua that's 8 years of age, and this is the first time they've come in, and they can't afford to go to that specialist that is going to be $800-900. So you say, nope, I can't help you. See, I have ethical problems with that. To turn away a client that can't be taken care of by a specialist because they can't afford it, I don't think it's right for us to turn our back. I think we do the best we can to help that client and that patient. And I will take that risk at being disciplined because I'm not going to turn that patient away. I think we're getting very idealistic here, and I think I'm not sure that the unintended consequences down the road aren't going to be negative for the profession. And I want to go one step further, and I noticed in your selection of the 2013 report on AHA that one of the authors is Kate Knudsen, past AHA president, who is a part of the author of this report. She is now out of AHA because she has changed her mind, and she believes that there is some value to non-anesthetic teeth cleaning in certain situations. And we like to be idealistic, but I think we have to look at the total picture. And I can tell you a good portion, not all, but a good portion of my clients cannot afford to go to a specialist, and a dental specialist. And we have a nationally renowned one right down the street from us, and we have a number of practices that I would say 50% of their practice is dental work. And I'm a little nervous about this discussion.
If I may, I think this is really well intended, but what we're missing here is when you put it into the rules that you must follow, you're taking away the decision of the veterinarian who the patient is right in front of to make the best decision for that pet. There's no way you can codify everything that's going to happen or prevent, and it would be just as ridiculous as Dr. Plowski had said about requiring an ultrasound on a bladder every time you got a urinary infection in the clinic. So while it's well intended, we shouldn't be taking away the veterinarian's ability to practice seen by as dictated by the patient and the clients that's in front of them.
Any other comments, public, committee?
I just had a question. To Dick's case there, if you inform the client that there's potentially greater risk without x-rays, is that below the standard of care? You said you take stand the court with the board, but if you've given them every bit of information and informed them of the risk, are you providing substandard care at that point?
Well, I understood that if I didn't take the x-rays because they could not afford it, I am practicing under the standard of care. That's what I heard. Because the client can't waive the standard of care. So what I heard was that if I don't take the x-rays, then I am at risk of a disciplinary case.
Right, that's if we make it standard of care, but as it is right now, you wouldn't be.
Well, I heard this is the standard of care. And I will tell you, if we didn't hear about the legal case, I was going to bring it up. I saw the case where the expert witness was a boarded dental person, and the person making this decision was a judge who had absolutely no idea what veterinary dentistry is. And he took the testimony of the expert witness, who was a board-certified dentist, and the veterinarian was a year out of school. So I remember that case very, very well. And so to me, the definition of standard of care is one expert here, another expert here. They give their testimony, and a judge who knows absolutely nothing about veterinary medicine makes a decision. That's the system.
That's what I would agree with.
So I think we have to be a little nervous about the cavalier idea of setting these standards. And I think what we're setting is minimum standards. We're not setting the standard of care. The standard of care is only, in my opinion, is only defined by the judicial system and who that judge is. I think we're setting the minimum standards by regulation. And I may be wrong on that, but that's how I look at it.
Question, Tara. Do you see a difference, as Dr. Sullivan just mentioned, in minimum versus standard of care practice?
I would say that I do, because the standard of care starts getting into specifics about the actual animal, the diagnosis, the treatment options, the treatment chosen, whereas the regulations, it's just a minimum, it's just a general approach to your veterinary practice. There are some specifics like premises standards, minimum standards, but standard of care, I would definitely say, as it evolves over time, it's more specific and higher than minimum standards.
Okay, so where are we going with this? The question that we were, Bonnie?
Actually, if you look at the law, and most of it is human law, there's one case, Williamson versus Prida, that ties all the human malpractice cases into a veterinary case. But when you're talking about standard of care, you're talking about the minimum standard. You're talking about the minimum standard of care, which is why my law professor called it the Dr. Do-Do rule. It's, what doctors in your area with your same education actually do. So it's a minimum standard. But I still highly recommend that you don't get involved in setting standards, because it really is something that needs to be testified by experts. And when you, and it is a dueling of the experts, but basically it's, this expert testifies, and, I get to ask questions. What is your experience? How many times do you actually see patients? There's academic institutions in this state that when I get an expert from one of those places, I just love it, because they don't even see patients. So they love to get up there and testify about the minimum standard of care, but they haven't seen a patient in 10 years. So it really is fair when it actually comes down to it. The problem in my case was that he was an expert. I mean, he was a boarded dental surgeon and testifying against a very smart, very good generalist who was actually boarded, but not boarded in that specialty. And the judge just didn't understand that he was actually giving the standard of care for his board-certified people, not for my guy who was a year out of school and a generalist. So it is a minimum. If you read the case law, and if anybody's interested, I'm happy to send it to you. But there's reams of human medicine case law that talks about what this standard is, and specifics about how you can't determine the standard if there's just because there's a bad outcome, or just because somebody would have done something different. That doesn't mean that this other person did not practice within the standard of care, because two people might disagree as to how to handle a certain issue.
I was just going to ask if you, Bonnie, or Dick recall about how long ago that case went down.
Oh, yes, it was
2 years ago.
2 years ago.
Oh, so recent.
Yes.
Okay, good, thanks.
I think you have specifics on it, right?
Well, I saw the
if anybody needs it.
I don't have the specifics on it, no. I can't look at closed cases.
Okay, well, I think we've vetted the topic, done our homework for the VMB's task. I will just ask if there's any motion anybody sees we should discuss, vote on to send back to the VMB. Have we concluded anything definitive that requires some change? Okay. May I ask we take a 10-minute break and then come back and tackle last item on the agenda, almost last item on the agenda, number 8. Minimum standards and protocol for pet ambulance. This was a topic that was tasked down from the Veterinary Medical Board at the May meeting. A couple of board members inquired as to the rules and regulations that are in place for pet ambulances. And I confess, just in the timing of the meeting, the wholesale replacement of MDC members. We just didn't have enough members to cover this, so I want to thank Jessica and Amanda and Tara for being responsible for pretty much everything that's in the packet here. So I want to defer to her about this material.
So the question was raised and potential concerns surrounding what regulation exists for the pet ambulances. The question was whether or not there is any statutes or regulations surrounding the issue, and if they're not, should something be done? So staff researched this. Amanda did the bulk of the research, so thank you, Amanda, for that. You have the pet ambulance as a premise, and if they are providing veterinary services as part of that premise at the mobile clinic, then that needs to be registered. The exemption for that would be if it's tied to an animal hospital and tied to that location, then it's already operating as part of that permit and is not subject to another permit. You also have instances where the ambulance is solely transporting the animal. So they're not providing any kind of veterinary medicine and therefore wouldn't be under the purview of the Veterinary Medical Board. You have the instance where, depending on what services are being provided in the ambulance, if veterinary services are being provided, then that should be done by a veterinarian licensed by the board who we would have jurisdiction over. There are some exemptions in there for RVTs who are providing emergency services that they can do, and they are under the board's purview. You have the pet ambulance itself under it qualifies as a mobile clinic and has to go under the regulations under 2030.2. So those are covered if they're providing veterinary medicine. So depending on what's happening, the board would have purview under it. If you have an instance where there's a pet ambulance providing veterinary medical services and it's not registered, you have the issue of unregistered premise, and then you have the potential for an unregistered practice as well, which we would have jurisdiction over. So there are statutes and regulations and guidelines under 2030.2 of what has to be in a mobile clinic, depending on what the ambulance service is providing. But there are also concerns raised by other organizations such as CHP who have people calling them and people who are wanting to do these transportation services and not knowing what the requirements are. And so CHP has raised concerns that there's lack of pet ambulance regulation. So perhaps one avenue that we could do is do more outreach. We can create an FAQ surrounding existing statutes and regulations and distribute that to organizations such as CHP to help distribute that information and also post it on our website. When we looked at what other states are doing, it's very similar to what's going on right now in California. There are other states who know that they're operating, and as long as they're acting under the purview of their license or permit, then they don't have concerns. So it really depends on what's going on in these ambulances. We also found that the general location of them is primarily right now in Southern California. There's a few in the Bay Area, but it's not a huge population that is impacting right now as far as California goes. So that's what our research has found. We do recommend that we proceed with an FAQ to post on our website and distribute with CHP to kind of help educate the consumers out there and the individuals who are looking and starting pet ambulances so they understand what statutes and regulations they could be held accountable for. So with that, I'll turn it back over to the committee.
Comments from the committee? Anybody live in Southern California? That wants to admit it. Well, I'm asking in all seriousness if you've ever even seen a pet ambulance. I never have.
Yes, not often, but there is a service in our area. The one incident that bothered me was a client who was disabled and couldn't get the patient. I think it was a larger dog. So she called this pet ambulance service, and the driver called me, who was an RVT, and said, "Oh, by the way, do you want me to give him any hydromorphone on the way over? I said, no, you can hold off on that till we see the animal. But I was just, I mean, usually I have a better answer, but I was so shocked, I couldn't believe that, that they're even carrying it, let alone asking if they could use it. I'm still somewhat bothered by whether, I better stop where Mark.
I know of one that a colleague of mine, old colleague, used to work for, who is also an RVT, that worked for ambulance transport, and her husband worked there as well, from homes to vet hospitals. I had inquired about it, and they had oxygen, I believe. I never heard anything about drugs, let alone controlled drugs, but I was surprised to find that. Now, I don't know anything about their licensing or anything like that. My other experience would be one emergency hospital I've been with has an ambulance, but it's part of their premise that goes from referring vets and brings them to them, and then a transport vehicle between specialty hospitals that has no services on board it.
In the example where your RVT colleague had was it a business? They owned the truck and did?
They did not own it. They worked for someone who did, but it was not owned by a veterinarian.
Okay. Any negative or experiences that you're aware of?
Not that I'm aware of.
Okay. Public comments? Anybody know anything, have any concerns about pet ambulances? Dr. Nunez?
I'm Mark Nunez with the Veterinary Medical Board. I don't think anyone has to leave the room because there's only 3 of us here. Is that correct, Tara?
There's only 2 of you.
There's a third one over there,
I don't think
the cynic on the end.
I thought they were talking about the audience.
Okay, well, I
Can't be more than 3.
this is one of the issues that I had asked to go to the MDC because I do practice in Southern California. I practice on the cusp of West Hollywood and Beverly Hills, so I definitely see a lot of things that most veterinarians in the state don't see. I certainly don't have any issues with mobile practices or mobile units that are associated with a fixed premise permits. But I've seen there's a lot of pet ambulances in Southern California, and Dr. Sullivan mentioned that some of them offer narcotic administration in transports, and many of them have oxygen delivery systems, and I don't think that they're regulated by anybody. I know that the board mostly responds to complaints, so my question is, do you know if the board has received any complaints in regards to any harm done to any of these animals that have been transported?
So complaints themselves are not public information, so we wouldn't be just able to disclose if we have received complaints. I can tell you that we are looking at this much closer, and we're looking at the whole issue specifically in Southern California as well.
Because, the delivery of oxygen certainly is indicated in many, many things, but not all things. And I think that that's something that's commonly done for these pets, not to mention whether or not these facilities even have air conditioning or proper ventilation or anything like sanitation in between patients that they're transporting. There's a lot of issues that I think should be addressed. I'd hate to see it wait for a complaint or an injury to happen, but it's one of the reasons why I wanted the MDC to talk about it.
Ellen?
Strange that these are some of the same issues that we bring up about animal shelters.
Yes.
Thank you.
Speaking on behalf of the California RVT Association, Lynn Moon, Our only concern is that the people who are operating these ambulances and performing treatments are doing so legally under the direction of a veterinarian, and that they, in fact, be licensed RVTs or veterinarians who are doing this. Otherwise, we don't have an issue with it.
What I would like to encourage those who see these clinics is to let us know as soon as possible so we can look at it more closely. We have found instances we don't have to wait for a complaint to investigate. We can be proactive. And so we can do that if we do notice that something else is happening. But we also encourage any other veterinarians or members of the public who know that these services are happening and has concerns, then to bring it to our attention so we can be proactive.
If they don't have a permit of some sort, is that within our jurisdiction without a complaint, or is that just illegal activity?
So I would
Treating
still
medicine?
encourage that to come forward to us to investigate, because depending on what services they're providing, they may have to have a premise permit or a license, whether it's an RVT or a veterinary license. And if they don't have either, then we could have the instance of unlicensed practice to where we would take action against that. So I would definitely err on the side of caution and request that everybody send us those types of complaints so we can investigate on a case-by-case basis.
Just one last thing, they're not cheap either. I mean, these trips usually cost $300 or $400. And so if they're charging that much to the client, I think the client deserves some sort of service.
Any other comments? Les?
I just had a question. If they're giving scheduled class 2 drugs and oxygen, isn't there a veterinarian associated with this somehow? Where would they be getting the drugs?
Yeah, so that's specifically something that we would want to look at, because that's a concern. Again, that's on a case-by-case basis. If there's an unlicensed person administering those drugs, or RVT's doing it without the direction of a veterinarian, there's obviously a concern here. So we want to look at it more closely.
Again, related to that, how timely, not timely, but how recent is?
That's 5-6 years ago. But I think that, there still is an ambulance, pet ambulance working in the area. I just don't know if it's the same one or not, but I'll get the information.
Okay. Well, it sounds like there might be some research that we need to do at some point here. No other comments. I'm going to move to agenda item number 9, public comments on items not on the agenda. Anything for next meeting? Okay. Agenda item number 10, future agenda items. Next meeting date is November 13th here in Sacramento. To review current priorities, complaint process, audit, enforcement. Dr. Klingborg at the last meeting, I think, summarized it well. He said this subcommittee tends to get together and provide reports about twice a year. So we'll shoot for whatever the following November meeting would be. January, I think the meeting cycle might change, so it looks like it might be January. We definitely are coming back to minimum standards for shelter medicine. The report to the VMB tomorrow on dental radiographs will determine if that comes back to the MDC, and then current pet ambulance issue. Motion to adjourn, please.
Second.
Thank you very much.